Welcome back to Medical Update. I'm your host, Dr. Mike Rosen. Urologists have used the same methods for diagnosing prostate cancer for the past 30 years, but things are changing rapidly with the use of new technology using magnetic resonance imaging, MRI, with ultrasound fusion guided biopsies. Our guests today believe that incorporating this new technology will have a significant impact on the diagnosis and treatment of prostate cancer. Dr. Ardeshir Rastinehad is the Director of Interventional Urologic Oncology at North Shore LIJ's Smith Institute for Urology, and Dr. Manish Vera is a surgeon specializing in urologic cancers. He is also at the Smith Institute for Urology. Welcome to Medical Update, gentlemen. All right, 30 years, really, there's really been nothing different. There has been a little difference over the years. The PSA and the way we use PSA over this time has changed.
To tell you the truth, yes, the way we look at PSA has changed. However, we've been using the same tools, a PSA and a DRE, to select patients for screening for prostate cancer, undergo a biopsy. The biggest thing today that we're changing is how we approach the situation. We know with the U.S. Preventive Service Task Force that the use of screening has kind of been downplayed. They gave it a grade D recommendation most recently.
I mean, prostate cancer is still a very important problem. I mean, if you read the newspapers, you look at the news, the evening news, you see all the controversy. We shouldn't be screening for prostate cancer, but the reality is prostate cancer incidence is rising faster than most other common cancers like lung cancer and breast cancer. In the next 50 years, the incidence will more than double as the aging population ages and becomes older.
All right, so the question is, I'm sorry to interrupt, but the question is, why are we seeing more cases? Is it because the population is getting older, and with age we're seeing natural cases of prostate cancer? Or are we doing a better job at diagnosing these cancers? Or are we detecting, because of that, cancers that really don't need to be detected?
It's probably a combination of all the things that you mentioned. I mean, as the population ages, we know that there will be more prostate cancer. Our screening methods are becoming more aggressive. More and more men are having PSA testing done and therefore being referred for evaluation. So it's a combination of not only of the aging population, but also more aggressive screening. And I think that's still important because the reality is people still die of prostate cancer. And unless you diagnose and are better able to evaluate what kind of prostate cancer you have, you won't know what to do. So it is important still to screen for prostate cancer.
I think it's important to understand, even though the two screening trials didn't really show a benefit, it's how you select the patients to be screened and then treated. They had a broad catchment area that treated everyone. You don't see a real difference until you get into intermediate and high-risk cancer. And how do we select that? It's been very difficult because all we used were charts. You had a biopsy, a random biopsy of your prostate. We took that information and then placed it in a chart. We looked, how do you fall on the scale? Is it going to be outside your prostate? Is there going to be lymph node involvement? And we determined plans. The most recent advance that we've had over the last 5 years is MRI imaging of the prostate. We've brought a new technology to the health system from collaborators at the NIH of bringing multiparametric state-of-the-art imaging to look at 100% of your prostate instead of what your biopsy showed, which only revealed about 1% of what was going on inside your prostate.
Let's back up for a second. So let's talk about, because we're going to get to this, and this is the big ticket here. But let's talk about what a normal guy like me coming into an office, how am I being screened right now? What's the standard of care?
You would have a PSA and a digital rectal exam. If either one was considered abnormal, you would undergo a random biopsy of your prostate looking for prostate cancer.
So an abnormal PSA is a level over 4.
That is also up for debate. There's age-specific PSA values. It's also a clinician's overall approach to how they view PSA as a test. I think the PSA causes PSA psychosis in some patients.
Yeah.
I mean, traditionally we would use PSA as our trigger point, but now we're smarter. We know that we have to look at what happens over time. Is your PSA rising over the last 2 years? What is your family history? Do you have a family history of early prostate cancer? So you have to take into multiple factors in terms of making a decision about whether or not to do a biopsy.
Oh, let me throw you out a problem. So let's say I'm 54, 55, never been to the doctor, and my wife says, you got to go to the doctor, and you get PSA, it's 3.9.
Well, I mean, so I would tell you, look, your PSA is above the age-specific threshold. There are a lot of other reasons why your PSA may be elevated. You do an evaluation, you check the urinalysis, you may be having an infection or an enlarged prostate. We might treat you for a period of time, repeat the PSA again in 3 months, and get a little bit of history on you before we decide just to jump towards a biopsy. On the other hand, I might do a rectal examination and I feel a nodule on the prostate and say, hey, look, You know, in context of the elevation of your PSA, you have a nodule, you might need a biopsy right away.
And if a person has a family history, that's a bigger ticket to a biopsy.
Absolutely. We know that patients who have a family history not only have an increased risk of prostate cancer, but they have an increased risk of early prostate cancer, which can be more aggressive.
All right, now you talked about a random biopsy. So explain what a random biopsy is. It's really like throwing darts at a wall.
It is. We use an ultrasound, and we have a grid, and we randomly biopsy a prostate in 12 areas, which is the standard of care, the 12-core biopsy. And unfortunately, the accuracy of that is only about 40%. So if you were a patient, you came in to see your urologist, your PSA was elevated, or you had some criteria for a biopsy, you had a biopsy. The chance of that biopsy being positive, 40%. Then you leave. But you leave with a negative biopsy. Doesn't mean you don't have cancer. And that's what the scary thing is out there.
In other words, you're saying a random biopsy is only going to detect cancers 40% of the time when there's a cancer there.
Yes. And if it's greater than a centimeter, you can almost miss that in 50% of cases from Emberton's data he recently published on and how well trust biopsy works.
In medical circles, that is just plain lousy.
It's incredibly inefficient, and patients do not understand this. And that's why MRI is brought into the armamentarium, because now you have 90% positive and negative predictive values with a test just looking at the prostate without even performing a biopsy.
Right. So explain what that is, and let's get into the details of what you're doing. You're actually doing an MRI.
Yes.
On a person that has an elevated PSA, or you're concerned about the PSA.
Correct.
So that goes first before the biopsy.
Correct, because we're finding that if you do the MRI after you have the diagnosis of prostate cancer, the utility of the MRI can be decreased because you have hemorrhagic artifact. It's not a unique native evaluation. It's been corrupted by biopsy trauma and whatnot, so we do it before.
And ideally, when you're going to have a biopsy, we want to have the most information possible. So why not do an MRI rather than just doing a random ultrasound biopsy or ultrasound evaluation of the prostate? We can now not only do our random biopsies, but we can look at the MRI and say there's a suspicious lesion at the base on the right side. We can target that specific area and make sure that that is or is not something significant.
So you're still doing the random biopsies, but if you see an area that's of concern, you're going to focus in on that?
It's not just focusing on that. We take the specific MRI information and target that area on the ultrasound fusion biopsy as one of the trials that we're running. This is the only second site in the United States using this technology out of the NIH, and it gives us a unique opportunity to actually say, this is what we see, and then we're going to target this as well. You still get the standard of care, because that's what people get today is a 12-core biopsy, but you get the unique approach that we're actually evaluating this new technology to biopsy those specific areas.
Let's take a look at the video.
All right.
You can explain what we're looking at. So set it up. What are we going to be seeing?
All right. You have the MRI that you had done previously. Your urologist has evaluated it, looked at it, and we decided that there's certain areas that are suspicious. The MRI will give us a whole 100% of the gland look, because initially a biopsy only targets the bottom half or the nearest part of the prostate. So the whole top half is unsampled. That's just the beginning of the game. So now you're able to sample areas that are not readily sampled, and you target specific areas without missing large lesions.
Why have you only biopsied the bottom part of the prostate?
It's the limit of the needle. When we do an ultrasound biopsy of the prostate, we're putting an ultrasound probe in the rectum. The prostate sits right on top of the rectum, and the biopsy needle goes through the rectum into the prostate. But you can imagine that the limit of your biopsy is the limit of the length of your needle.
So you're hoping that if there's cancer on the bottom, there's going to be if there's cancer at the top, there's going to be cancer at the bottom. That's what you're hoping for.
That's what you're hoping for. And we know that the majority of cancers do occur in the peripheral zone of the prostate, and that's why ultrasound biopsy has evolved as it has. But there's a significant amount of cancers that can be in the anterior or the top part of the prostate, which can be missed by a standard biopsy.
Let's take a look.
So here you can see your MRI. There's a cartoon. This has been marked where the tumor is. And when we look on the top part of the prostate, this is the ultrasound outline of the fusion, and the biopsy is taken in this area. We perform this in 2 planes to get good sampling, so this is just looking at it from another angle. We're able to take the information, apply it to our ultrasound, and perform the biopsy as the needle comes in to target that specific area.
And this is only being done in your institution?
It's us and the NIH for this technology. Other people are developing similar technologies, but this technology has been developed for approximately 8 years. And this is the first time it's been tested outside the NIH in the United States. It's a unique opportunity. We're really excited to be able to collaborate with them. We're bringing multi-parametric MRI imaging state-of-the-art to the community as well. It's really important for us to give the best care we possibly can give to our patients.
And the other part of it is that we're a team. This is not just one person reading MRIs, not one person doing biopsies. This is a team of urologists, oncologists like myself, interventional oncologists like Dr. Rastinehad, plus radiologists that are looking at the MRIs all together. So we really have a team approach to making sure that we perform the optimal studies, optimal biopsies on these patients.
Now, are you doing this on all patients? Are there patients being admitted into the study? 'Cause this is experimental. This is not standard.
It's experimental, but if you have an MRI positive lesion, you meet criteria for the trial that can undergo a biopsy. So if your urologist has an MRI that's positive, we have a way to test this technology and biopsy those specific areas for you.
But you're not doing MRIs on every single man that goes in there for PSA.
Not yet.
Not yet. But we're trying to work this into the screening paradigm, because if you don't have any visible cancer, the chance of you having clinically significant prostate cancer is less than 3%.
Well, now you're opening up a whole can of worms, because I mean, MRIs are not inexpensive. There's not a radiation exposure, but there's a whole list of things that's going to raise a lot of eyebrows as to, are you really going to do an MRI on every single guy that gets a PSA?
I think going back to earlier that we have to still incorporate PSA. We still have to incorporate family history. And if we can identify a subset of men who may be at higher risk for prostate cancer and really focus MRI on those patients, we potentially could reduce the cost. And really, there may be a future in which a man at the age of 50, just as if your internist would say it's time to go get your colonoscopy, you come in, you have an MRI, we look at the MRI and say, look, your MRI is totally clean, you don't have to come back for 10 years. Or maybe there's an elevation in PSA, maybe there's an abnormality in the MRI, come back in 5 years, and start to really stratify which patients need more aggressive screening, less aggressive screening, or no screening at all.
Or perhaps one MRI, and then you follow the PSA along, and if the PSA starts to rise, then it raises the eyebrow.
Absolutely, absolutely. So in the long term, yes, there is a cost that's associated with MRI, but in the long term, over the course of 30 or 40 years in which patients are being screened, there may be a decrease in the cost by reducing the number of visits, reducing the number of biopsies, and potentially even reducing the number of men who need treatment for low-grade prostate cancer.
The naysayers are going to say you're going to pick up more cancers, even more cancers that don't need to be addressed.
It's not the point of picking up more. It's being smarter with the information you obtain. And I think patients, when they understand that you looked at an MRI, they can see it, you can see it, you can keep on active surveillance. If they had a small tumor, we see it, and they're like, I understand, doctor. I can understand what you're thinking here. It's small cancer. In the past, if you had think of a basketball and a biopsy needle. If you hit the biopsy needle down the middle of the basketball, that's going to get 90% or 100% of the core. You just cut the edge of the basketball with a needle, it's 5%. You still have a basketball you've biopsied, and the amount of cancer that you detected was how you sampled it. So you can get 5% or 90% of a biopsy core, and just how you accurately assess the patient. The MRI looks at 100% of the gland. And it's like that patient that has 2 previous negative biopsies and comes to your office, his PSA is still going up. He's like, Doc, what do I do? And I go, MRI is a perfect thing for you to be evaluated. It gives us a better look so things aren't missed.
This is great stuff. It's fascinating. Congratulations on getting the trial. I'm looking forward to the controversy. Thank you very much.
Thank you so much.
And thank you. We'll see you next time.